Welcome, everybody. For those of you who don't know me, I'm Vicky Bungay, and I'm a professor in the School of Nursing and the Associate Director of Research and Teaching Scholarship. And unfortunately, our director has been sidetracked and is unable to be here, so I will be your host for the evening. And we're so welcome, or so happy to have you join us for the 55th annual Marion Woodward Lecture. And before we start, I would just like to begin today's event by acknowledging that the Musqueam, Squamish, and Tsleil-Waututh people are the original inhabitants of the unceded land, which is now known as the City of Vancouver. We're joining together in person, physically, and also I think we have about 50 people joining us online as well. The School of Nursing here on the Vancouver campus is continuing our work to further integrate Indigenous cultural safety and anti-racism more widely throughout our programming, and particularly to uphold our commitments to truth and reconciliation and the calls to action in order to foster Indigenous health and human rights within our community and abroad. And so I would like to invite Elder Thelma Stogan and Arthur Stogan, respected members of the Musqueam Nation, to share a territorial welcome with us. Welcome. Thank you.
Good evening, my dear people. My English name is Thelma Stogan. I'm from the unceded territory of Musqueam, which is right down by UBC, not too far from here. My ancestral name is Loch Liuch. I'm a survivor of residential school. I went to two of them. I was taken away at the age of 7, and I didn't return home until I was 16. I would like to start off by welcoming you all to the unceded territory of the Musqueam, Tsleil-Waututh, and Squamish people. I'm going to let my brother say a few words. I'm going to let him get a few words in anyway. Thank you very much. I hope that you all return home safely, and all my relations. Hi, Chika.
Good evening, everyone. My name's Arthur Stogan. My sister and I are from the Musqueam First Nations. Like she says, we're about 3 miles east of UBC. And we're here tonight to welcome each and every one of you into the Musqueam, Squamish, and Tsleil-Waututh shared traditional territory. And, you know, the reason is that, you know, we were told it's the nurses that are here, and there just isn't enough. You know, when you go to a hospital, you see all the people that speak. You know, some people speak good words and some people speak bad. But we let it go through one side and let go out the other if it's bad, and we hold the good things. So we really, really put our hands up in our traditional way to say thank you, Haichka, in our language, and this is also to welcome you into the territory. I really, really appreciate you inviting us here tonight to welcome into our territory. And as you know, before we leave anything like this, I always ask the Creator to put his hands upon each and every one of you when you leave this place, just to make sure you get home to your loved ones. It's an important thing to us. So I put my hands up to each and every one of you being here tonight. And may you all have a wonderful evening and a safe trip home when you're done.
Yes, thank you so much for the warm welcome, and may you have a lovely evening as well. I know that you have other commitments and are incredibly busy, so we're deeply grateful for you to come and to welcome us into your home. Thank you. I'd also like to add that we're grateful to Mr. and Mrs. P.A. Woodward Foundation, which has generously supported the annual Marion Woodward Lecture since 1969. And we're excited to be here and to be able to be in person in the way that we are today. And we've got a fantastic panel that we're going to move into now, and I'd ask our panelists to come on up, and I will do introductions. We're going to have a seat up here. Everybody's got a mic, and I'll join. Thank you so much. Yeah, really. And one of the things that we have been very fortunate and very committed to within the context of our Marion Woodward lecture is that each year we also have this fabulous opportunity to invite our early career scholars and emerging scholars in the particular topic area to come and participate and engage with us in a lively discussion. And so today it's my, I really do hate having to read like classes off and on. But today I get to introduce Dr. Fatawu Abdulai and Dr. Kristen Haase, who are truly early career researchers who are both assistant professors in the UBC School of Nursing. Fatawu works in health informatics, human-computer interaction, and health technology design. His research explores how computer interaction and trauma-informed care can be leveraged to address inequities in access to sexual and reproductive health care. Kristen's patient-centered care research highlights the complex needs of older adults with cancer and their caregivers when managing cancer treatment. She's co-designing digital tools with older adults whose needs have historically been under-considered within the digital space. And Lori Block is a UBC nursing doctoral candidate and member of the Vancouver Coastal Health Clinical Informatics Community Team, where she leads the implementation, development, and support of an electronic wound documentation system. And it's my true pleasure to also introduce, and I will go into more detail when we have our keynote, but our honored scholar, our Marion Woodward Lecture Scholar, Dr. Ray Walker, who is an associate professor at the University of Massachusetts Amherst, where they co-founded Health Tech for the People, a multidisciplinary research group focused on tech ethics and accountable design. Their scholarship focuses on community-directed health innovation and digital defense against technologies and data regimes that cause harm. Each of our panelists' bios are, we'll put up the next screen, but for our panel, there is a QR code that gives all the details and much more detailed bios. But please join me in welcoming our panelists. And how we're going to do this is I've got some questions posed and ready to pose, and we're going to do a question and answer with each of the panelists, and we'll see how time goes. I know we're on a bit of a tighter schedule than we'd originally planned, and we'll wrap up at 6, and then we'll have the opportunity to go out and have a light box lunch and socialize and come back in for our keynote at 7 o'clock. So welcome everybody and thank you. And I will move now over to this seat. That's a hot seat. Here we go. Okay, there we go. Lori, we're going to start with you if that's okay. Wow, that's a bit loud. Lori, this is as someone situated within a health authority setting and a specialist in clinical informatics with amazing specialization in considering language and technology in the context of healthcare and health equity, what do you see as some of the greatest areas of possibility to advance nursing leadership in this field?
Hi, everyone. Great question. And I was thinking, how can I kind of structure some complex thinking I have around the topic, but just to kind of lay the land. The things that I'm going to think about and discuss with a story are data as a byproduct of care, a topic that Dr. Leanne Curry first introduced me to. I'm thinking about some of the pillars, some of the areas of nursing, such as justice and equity, privacy. So we'll think about that. And the last piece is about scope of practice in nursing, some of the regulatory and some of the professional practice leadership opportunities. So I'll start with a story. It's a future, so it's not real, but it's not that far. So imagine you're a home care nurse. So I'm a wound care nurse by trade. So you're a home care nurse, you're seeing a client in their home, and with you, you have a bag of wound care supplies and a smart watch. You turn your watch on, you go see your client, you're interacting, you're talking. How is your pain? How is the care provided? What's working for you? What's not working for you? You take down maybe an old wound dressing. You've got your wristwatch, take a picture, some assessment details. And as you're continuing your care with the client, you get a buzz on your wristwatch saying patient has, based on the assessment, based on the details that we've collected through just listening to the conversation, based on the picture, we're suspecting or recommending the potential diagnosis of a venous ulcer, but it could be a venous arterial mixed ulcer. It could be someone also potential for cellulitis. And then it provides intervention recommendations such as we're going to put a topical antimicrobial, a silver dressing, and a foam. We're going to suggest some blood work. We're going to suggest a wound culture because of the potential for infection. Nurse continues their care. They go maybe to their electric car, just validate the charting, and it's submitted. So with that scenario, it's not that far off, right? We see companies that are right now in BC, we have nursing leadership looking at how listening to a patient conversation, the natural language processing software, and then pulling out the salient points. So that piece of work is being considered right now. We see Canadian companies, an investment of $4.3 million through a big digital supercluster here in Canada, looking to advance how the photography can look at three-dimensional measurements, how it can do synthesis to look at the biome or the bacterial burden on the wound, and heat register. We have automated decision support providing recommendations for diagnoses or predictions and the risks that go along with it. So within that story, you ask about the opportunities to advance leadership. And so one of the pieces that I think about in the health authority setting is that data capture as part of care. And so often I think some of those conversations, it doesn't have to be AI. It could simply be just part of our care workflow. They can be cut. Those things on a business case, on a project, don't always get the light of day. And so thinking about how to improve the care, coordination, and trajectory would be something I'm hoping that we continue to advocate for, especially for practicing nurses. The second kind of thought I have around that topic, consent. Do we think about how we consent or patients consent to being recorded with some of these advanced technologies? Or thinking about the justice of how those machine learning algorithms are being developed and which kind of data and whose data it is we're thinking about. So again, for nursing leadership to be aware of these concepts and really drawing upon those principles we think about in nursing and the equity lens as well. And then finally, just again, this is brief, could go into a whole day of this discussion, but thinking about the regulatory. So in that example, we said, well, maybe we're going to have a pop-up recommendation of venous ulcer, venous arterial mixed ulcer, and cellulitis. I'm a wound care nurse, but within my scope of practice, I can't diagnose cellulitis. I cannot prescribe antibiotics. That's not within my scope. And so I question as we continue to develop some of these advancements in technology to think about our scope of practice and to look at our college and our association to ensure that what is being designed and built is appropriate for our practice and speaks to what our practice needs, and to ensure that we don't become tethered to just being the information gatherers and senders, informed physician if it's cellulitis. Well, no, that's part of our conversation and care. However, much of that can be automated and it can't just lay on the nurses to fetch that information back and forth. I'll just pause there. That was a lot.
That was great. Thank you. So what we're gonna kind of go through this sort of we're gonna go through this kind of one kind of thing and then allow and encourage our panel to kind of discuss this amongst themselves as well. So I have other questions, Lori, but I'll give you a break for a second. So Fatawu, in your work concerned with design and evaluation of digital health interventions, you've identified the importance of considering trauma-informed care frameworks and health equity. Please tell us more about why a trauma-informed framework is so important in our digital health interventions.
Okay, thank you so much for this question. And for almost everybody sitting here, I don't think I will be introducing trauma-informed care because is something probably everyone might have heard or might have worked with, because there have been increasing calls for trauma-informed design of social and healthcare services, and it's been taken up in Canada and other places. But at the same time, over the last couple of years, 5-10 years ago, even most recently now, there have been increasing adoption of digital health technologies across these institutions, health and social services as well, and mostly, especially for our patients. Now the question is, how do we develop these technologies to be trauma-informed? Given the fact that these are mediums through which trauma can be perpetuated or even trauma can be triggered. So that is the whole essence of why I am actually working in this area, is to see, okay, now we have actually implemented trauma-informed care in health and social settings, still being implemented. How is it being implemented in digital spaces? And now, right from how systems are being conceived to be developed up until implementation and until when they are deployed, there is enough evidence to show that practices along each of those processes can lead to trauma. And why is this important? If we look at this history of digital health, the essence was to actually provide healthcare to people that do not actually have access. And this happens to be mostly underserved populations who do not have access. And underserved populations, if you look at the literature, has a disproportionately high rate of trauma. And if these people whose these interventions are meant for kind of experiences trauma in these technologies, then you could see the compounding effect of trauma that it could have. So there'll be enough evidence of how digital health intervention could be harmful. And either through so many other mechanisms, even how content is displayed could be harmful to somebody. And somebody could have previous histories of trauma that they might have probably forgotten about. But if they go into a digital health intervention, let's say they open up an interface and see something that they do not actually like, it could trigger a trauma. So these are the concerns. And even though the whole idea of trauma and violence-informed care as applied in digital health is for everybody, but the concentration is actually on underserved populations because of the underlying principle of enhancing healthcare equity to this population. And if that is the objective, then the least thing we want to do is to actually see these interventions as mechanisms for perpetuating perpetuating trauma. So that is why I think this is important. And I feel like, okay, in the digital health space, of course, it's interdisciplinary and mostly championed by what I would say software designers and developers who probably has little knowledge of what trauma and violence-informed care means. So now, how do we penetrate this? And as a healthcare professional and also a researcher with healthcare background and learning in this space of technology and trauma-informed care, my objective, because I understood trauma-informed care based on the literature I've read, my objective is to see how these other group of professionals who play a vital role in digital health development and deployment can get to understand trauma, but not necessarily in healthcare. And it is crucial because I could advocate, but somebody, a software engineer who is developing a system doesn't actually understand anything about trauma-informed care, it will still be problematic. So the essence of this research area is actually to see how digital health interventions would not act as medium for perpetuating trauma. If they cannot help people to alleviate trauma, then they should not be avenues for perpetuating trauma. So that is the essence of my program of research and then why I feel it is important.
Thank you. I'm not going to let you off the hook, though. I have another, just a little bit, because I think it would be great if, so where are we at now, like in this field? Has there been much work done in this area of thinking about trauma-informed care and frameworks in digital health?
Well, I would say if you do a simple Google Scholar search, you get minimal literature on trauma-informed care as applied in digital health. But we have a couple of some folks in computer science that have picked up this topic. But what you see is that they are rather focused on trauma-specific, trying to use digital technology to diagnose trauma, which as a healthcare professional and doing this research, I feel like it's not actually the right approach, because that approach, that mechanism is actually perpetuating trauma. And being trauma-informed, I would say in this field, is about reflecting, continuously reflecting and adapting technologies rather than just having something like a one-time checklist. And of course, the work is still in infancy stages. And to move it forward, I feel like, okay, to even understand the solution, to get the solutions as to how to develop trauma-informed digital health, then we have to understand the problem space properly. And we actually put in ethics for one of our studies to actually understand how how technology-mediated trauma manifests in digital health technologies. And currently, we are also running a scoping review on how trauma-informed care is adopted in digital health technologies. And this is the studies we are seeing. What we are seeing so far is pointing to trauma-specific approaches, and which is not the right way. So now moving forward, we want to understand the problem space, understand the possible strategies that can be adopted, and provide recommendations that can help guide system developers, technology developers in general. And my focus is actually on the tech community, because for healthcare, as I said, almost everybody here kind of have a little stint of trauma-informed care or what trauma means. But people in tech community, yes, that is not the area, so you can blame them. So they don't understand that. And how do we get them to understand that? Because as somebody in digital health, I work with a lot of people from the tech, and it's important for people that I work with. They try to kind of get the healthcare perspective of things, but it's not everybody in tech that actually work with healthcare professionals. So I think that is the space is still at infancy, and if anybody wants to work in this area, you are invited.
There's a hook. Thank you so much. Kristen, in your work with older adults, because we're seeing themes going across here, but in your work with older adults and caregivers with cancer and chronic illness, you're tackling the use of digital tools and the importance of meaningful inclusion of older adults in the creation of such tools. Can you tell us more about the importance of meaningful inclusion, including perhaps some of the historical aspects of inclusion or maybe exclusion of older adults within these digital health tools, please?
Thanks, Vicky. Hi, everyone. Yeah, so I think thinking about meaningful inclusion, it's always helpful to think about the population you're working with and maybe flip the question the other way. And what is meaningful inclusion to the population that you're working with? And so, with my population with older adults, one of the historical problems has been their exclusion. And so digital tools, apps, whatever they are that they're supposed to be designed for older adults are designed for older adults, and then older adults are not able to use them, or the tech fails because they weren't actually designed with older adults or co-designed with older adults. Maybe older adults are brought in to go through some of the late stage evaluations, but they aren't sort of at the table during those early decision-making processes and kind of deciding which way things are going to go. And I think that level of inclusion can be really helpful as we design these types of tools. But I think it's also really important when we think about meaningful inclusion and we think about authentic inclusion, that we think about our populations, again, what they want, because sometimes our standards for inclusion are full cycle inclusion. We want people who are going to help us conceptualize the research problem and work all the way through. And in a lot of the patient-oriented and community-based research we've done with older adults, they'll say, I'm not really interested in that. I don't have time. I've got grandkids and I've got other activities and volunteer work, and I want to be involved. And this is what inclusion and involvement looks like for me. And so I think we have to create space and create room for different types of engagement at different parts of the design process that sort of reflect the interests of the population that we're working with. And I'll just add maybe one last piece around exclusion. And I think this underpins the exclusion is related to ageism. And ageism is one of those things that is really, immersed throughout our society. There's a lot of self-ageism. We make jokes about ourselves as we age. And so, it's not just that older adults sometimes maybe have, varying capacity to do certain things on their phone, but we actually also, sometimes they feel like they can't because of this self-imposed ageism, because it's so prevalent in our society. So I think as people who are involved in the digital health space and working with older adults, we really have an opportunity to sort of flip that script and say that this population, they're engaging with tech more and more. So how do we create experiences for them to engage in meaningful ways? And I think, our colleague, Dr. Lillian Hung, who's not here tonight, I'll give her a shout out. She's also doing really interesting work with different types of technologies that allow older adults to get involved and, really co-leading some of that work. So I think it's sort of our job to think about meaningful inclusion, inviting, people to participate in different ways, but also reflecting some of our biases about who wants to be involved in tech, because we do have a tendency to think about it as being younger people, but 75% of people who will be diagnosed with cancer in BC this year are over the age of 65. So we need to think when we design these types of interventions, who are we designing them with and who are we designing them for?
That's great. Thank you. And before I go into another round, Dr. Walker, I'm just curious, as you've been listening, and things that are standing out, or any comments or queries that you might have for our panelists here.
Wow. Well, first of all, I'm just very humbled to be sharing space with this panel of scholars. And while I love my job, I wish also I was a program officer that I could just write checks for this entire panel to further the work, because there's so many things that were coming to mind, and I am hearing themes and also, things I hope I can speak to in a little bit too, but I'm almost like, why will I speak? We've got it all here. But this idea too of labor and relationality, which I heard, coming out with Lori in this talk of, nurses not just being information pushers, right? There's a relational piece of that care that you can't just flip a switch on. And Fatawu's, comments about trauma-informed care, it brought to mind how nursing has things to offer which maybe haven't been at the level of, say, AI, but just how much folks in this space have done to sort of understand that, so that we all have access to it. And I loved sort of this idea of shifting back the attention to, like, let's look at who is the expert here, right? Is it necessarily just someone who knows how to build tech, or is it the folks who have the lived experience who can inform what, the needs really are? And then everything you just said about, inclusion and participation, and this idea of being flexible and really listening and not just imposing your frame. I think I'm just going to be here cheerleading the whole time.
Cheerleading's great. That's great to have cheerleaders. So in drawing on that and just thinking some of those kinds of things is, so Lori, I'm wondering if, given your example, which was just so real and so vivid, and you highlighted some of the challenges around where nursing fits, but what do you see some of the roadblocks we might be facing to optimize these interventions and support for quality and equitable patient care. See. It's okay. Take a moment.
Yeah, no, it's a great question and roadblock opportunity, opportunity to further the work. So, one of the things that I've really been thinking a lot about, kind of back to even the design of these advanced technologies and the placement of these technologies within our nursing practice, thinking about how our practice may change, how the technology may still yet need to change to support our practice. And I do worry, and I wonder if our eyes are open in how some of these AI, machine learning driven automated decision support systems are being built, and ensuring that it really is being built for our practice needs, that there is nuance, that it comes alongside our practice and supports our decision making, and that it's not centering medical-based data or interventions or diagnoses. I see it in some of the settings where often it becomes a workaround. I'm in informatics. We write workflows. That's our bread and butter. How do staff interact with the system? And I read these amazing documents that people have spent lots of time working on. But often when I read the nursing workflow, they've interacted with an element of decision support, and then the outcome is a medically based diagnosis or intervention, and the action is nursing to call doctor. And while I'm not detracting from the importance of collaboration and what that discussion and interdisciplinary work is about, it's the point that if we're writing and designing based on that model, I question then if it's used to practice of nurses. And so again, it's pushing back and as a roadblock or an opportunity, how we frame it for nurses, nursing and research and education and administration within our policies. Like I asked the college, in my mind, I think, do we need a statement or a white paper, or does our association need to state that the use of AI supported technologies needs to be within consideration of our scope? And so that's where my mind has been of late.
That's great. Thank you. Anybody? I can see nodding all around. So I'm gonna open to see if anybody has anything to add to that. No. It's okay. We're intentionally allowing, just allow it to happen. So thank you, Lori. That is it brings us back to thinking about over the decades how technology in its various different ways have played out in nursing, and when and how it's been almost that, I like how you say opportunity, but also that flipping things around is a tool that was almost surveillance, and in the work that we do and those kinds of things. And again, how do we put it within our scope and our practice? So thank you for those thoughts. So Fatawu, you mentioned that you in your work, you're thinking about the folks, what we'll say behind the scenes, the technology people who are building out, and so thinking about working in that environment and trying to increase awareness, and what do you think are some of the priorities within that, try to move that group along? You spoke to this a little bit, but how do we move that group along into integrating these kinds of frameworks?
Okay, I think in terms of capacity building with regards to trauma-informed care approaches, honestly, at a higher level, I want to see us people who are engaged in either designing, evaluating, or deploying digital health technologies, or even using them, to look beyond just trying to respond to the needs of the end user, but to see how the larger systemic factors in computing and the larger systemic factors in society kind of interplay with digital health technologies to perpetuate stigma. And how do we do this? First, I would believe like adopting an intersectionality framework and across all team members, right from research to generate user requirements to inform development and throughout the development and deployment stages. Because if you are setting out to develop a digital health intervention, as a team member, or I would just say a team member, you have to assess your own positionality and try to understand the population you are designing for. Assess your own positionality and see how it relates and differs from what the population you are dealing with. Because it's important in the sense that a lot of people go into this, not necessarily go into this, but everybody have their preconceived biases, which doesn't necessarily might conflict with the intended population you are trying to develop for, especially talking about issues of trauma. You may not probably know what people has gone through in life. You don't understand historical factors and systemic factors that they experience in life. And when I think of this, I'm just learning so much about, especially with the trauma-informed space, I'm learning so much about indigenous histories and then learning everything. And being careful about the fact that you don't try to, you are going with the intent of helping, but you don't know what could be harmful. So trying to understand people from where they are coming from, understand their position, is really, very, very important for everybody who is involved in sustained development. And also adopting the interdisciplinary approach, working with, technology design just goes beyond having ideas about tech. You have to think about even laws in some instances and understanding societal barriers in making sure that you really, really don't produce harm in trying to do good. Ideally, a whole education framework, I don't know what to say, having some, I don't know how to sensitize tech community who are involved in digital health design and development and evaluation and deployment. It's really, really important to get them sensitized on even trauma, how their interventions could be harmful. And as Laura was saying, she talked about AI and then these advanced technologies. We are in the digital revolution and everybody is excited and probably not thinking about how this could be harmful to people that would most benefit from this. So it's really, really important to look at the other side, especially with the digital revolution. And if people who are involved in design and evaluation of digital health interventions have an idea, not to become trauma experts, but have an idea that, of the other side of things that could inadvertently occur through their virtuous intentions, I think it will help. And while we advance in the digital revolution, to make sure that we think about the underserved population that these interventions were originally meant to help. And there's been available evidence that shows that digital health interventions are mostly adopted by and most useful to affluent and highly educated. And of course, I was saying in class today that, something may be successful, but do the analysis to see who is benefiting from it. Okay, I think this is what I have to say and respond to this.
Thank you so much. It's like the teasers for what's going to come later today, I think. And Kristen, just thinking about, that staggering statistic of the age, of the people being diagnosed with cancer, and what, in your experience or in your visions, what do you see on the forefront for folks in terms of how these digital tools and health interventions can be helpful, given who is going to be diagnosed and at what point in their life, and what do you see are some of the possibilities for these tools and resources?
Yeah, I think there's endless possibilities. And I think Lori's example is a great one of how technology can be mobilized to capture lots of data and do all of the things that we need it to do. I think maybe it's helpful to step back and think about what our healthcare system requires of people to do to maintain their own health. And a lot of the work that I do explores the concept of self-management and that labor that we do require people to do to maintain their health or to manage health in times of acute healthcare crisis. And so a lot of the times when we think about digital health tools, we're designing things and how do they meet the requirements of the healthcare system? And how do we exchange data? And how do we make those privacy connections? And I think that that's great that folks like Lori are so good at that and so switched on. But I think sometimes it's helpful to actually flip it a little bit and say, okay, if that's going to take 10 years and millions of dollars and we're never going to be able to make the connection, what are the types of tools that could help your family member who's been diagnosed with cancer and needs to learn how to manage their symptoms now? So is it always necessary that we have to be creating complex systems that connect to complex systems? Or can we create systems that allow people to support themselves and manage their own health? And they can show that to their healthcare provider to support that connection and collaboration if they choose to. But at the end of the day, when their cancer treatment finishes, or when they're, when they are discharged after they have a cardiac event, they're at home managing their own health. So what types of interventions are helpful for them to continue to do that work? And I think increasingly, as we think about, we have an older population. We know that as we age, we sort of kind of collect different comorbidities and how do we, we talked about silos beforehand, silos across systems, multiple providers, multiple systems, multiple pieces of data. How do we empower people to manage their own data, right? Like what kind of systems and what kind of work can we do that can support that kind of work? So that's kind of where my thinking is on some of that work. And it's a bit, as you can see, some of it's not fully formed, but feel free to finish some of my thoughts in a more articulate way.
My head is swimming with thoughts. I have to edit, but I don't know if you saw my head bobbing, but I'm like, yes. So one thing that came to mind was, these sort of design justice themes, I'm hearing, and one of the principles of that being, of course, that, you have to look around and see what's working. You have to understand too, what's the sort of traditional knowledge, the indigenous knowledge, the things that were already there that we don't have to reinvent because it's there. And the low tech movement, if you all are familiar, you hear about high tech. The low tech movement is very intentional about that. I still live in a rural part of Massachusetts where I think 22 townships in my vicinity still don't have access to high-speed wireless. So every solution we build that requires a heavy loading onto a browser, if somebody even has access to the internet, it's still not going to work properly. And so to your point, what do we have that does work? And then also, the idea of what we focus on and simulate, back to the trauma-informed care and the violence that people can experience at sort of in that interface, right? It popped into my mind. I'm aware of this because of Alex Hanna. I'm not sure if Alex was the one who created it, but they created an administrative violence simulator. Like, how we have clinical simulations, people, we make students or even individual nurses, whatever, go through, and then we sort of rate them on how did you do? The administrative violence simulator came out of sort of trans community as just one of the many communities that these systems were never built for in the first place, right? They just weren't built. They weren't built by people who were thinking like, oh, let's, create more expansive possibilities. They were just built. And so it's where you get to choose your own adventure as you go through the administrative violence of trying to access care as I think in this case, as a trans person. And every stage you level up. It's like, do you get to choose to misgender yourself on this form or not have access to your medications? You decide. And then it kind of takes you on. And it got me to thinking too, how the tech community can build things, but so often that focus is on like, well, let's just find a better app to help, to help these people we've imagined have this certain problem. Whereas there is also this opportunity. Simone Brown gave us this idea of surveillance, which is where you stop sort of just looking down, from kind of high up, and you sort of turn the lens back up at the system, as you all were saying, and use maybe some of these capacities too to look at that and to name that and make it transparent, including, I love the labor themes, these themes of the work, the labor that Lori brought up, and also Kristen, which was my dissertation topic, was the work of illness in the context of managing cancer care. So I just want to work with all of you forever.
Come on over. We're very friendly. That's very good. Thank you so much. What I want to do is, if people don't give a chance, if people have some questions, we've got a few minutes. We've got about 5 minutes or so. So I'm going to stand up so I can kind of just see a little bit. So if you just want to put your hand up and speak up, it's and I can pass around or the mic, or if you can speak clearer and I can just repeat the question. Have we got some online? So if we'll just check. Anybody have a question? Please go ahead. I can bring you a mic here. Here we go. Oh, yeah, thank you. There we go. If I can take that off. There, yeah.
Can everyone hear me? Ooh,
Ooh,
that's
yeah.
loud. Can people hear me?
Yeah, thank you.
Okay. My question had to do with the use of AI technologies, and I know Lori had mentioned about it being a part of our scope and using it as kind of a clinical decision tool. I'm wondering where you see that coming into play for like new graduate nurses who are new to the field. Do you see it as an educational opportunity, or more so something that can be used throughout your entire profession?
Yes and yes. Yes, I do absolutely hope that the ideas around AI, and again, I think just drawing upon the spectrum of considerations with the use of applied AI eventually. I think right now we talk a lot about it. We're researching, there's a lot of research and development in the space, and it's emerging right now in practice in small pockets. And so hopefully your education has provided you some of that context, and really we can lean on the principles of nursing, right? It's understanding the technology and things like machine learning, and knowing that it exists based on data, and interrogate the data. Are we looking at data sets that have bias, that embed racist interventions, that are not equitable? So that awareness, and then through your career, as these technologies unfold in front of us, also the awareness of, is it appropriate? Also knowing the cost. We have to make some heavy decisions in healthcare if we're going to be investing, and thinking what the trade-off would be. Not that I'm, I think, directly answering your question and hopefully providing little aspects to the answer, but yes, hopefully as a new grad, you'll be interacting, thinking and bringing your principles of nursing, advocating, considering justice in the use of the technologies, and participating in, if things aren't working, be a voice. And maybe I'll open it up to my other colleagues here. Is there any follow-up?
Great, thank you. We do, I'll just go online. This is anonymous, so I can't give a name or introduce anybody. But the question and comments start. Cell phones, data plans, internet are expansive. Moving forward, as we see more basic things become digital, how do we keep the relational aspect? For example, in vital sign monitoring with text response, basic appointment bookings, those sort of things. How can we keep the relational aspect in these kinds of things? And I'll open it up to whoever wants to offer an answer.
Yeah. Go ahead.
I hope to talk to a little of this in a bit, but I think it's one of some words that came to mind was just like, well, we got to keep fighting to keep the human centered and human centered. And I think maybe to borrow from some of what our panelists have already shared, it's the actual process of being in relationship with a person, the process of accompaniment is not simply pushing information in one direction or another. And that labor, that work is not captured in much of what is written down, particularly in digital systems. And I'll say a little more about that in a bit, but I guess that's a teaser for some thoughts I have on that.
Okay, I think that's a great question. And this question raised was an aspect that I looked at in my dissertation, not actually explored, but came up definitely, which is the fact that what you just mentioned in that question is physical, like not physical, but tangible functions that digital health interventions can perform. But the reality is that people's needs transcend these tangible things to include the emotional and relational aspects that people feel. But the question is, how do people encode or code empathy and emotions in digital health? So this is the whole question. And coming back to the tech community, I've read a couple of papers that seeks to detect emotions with patients, but those were developed from engineering perspective. Now, how do we as nurses help in informing or developing this thing from the humanist perspective so that you can incorporate this emotional and relational aspect that are so dear to end user patients, but hardly difficult for engineers to develop. So this is an interesting area of research in digital health on a human-computer interaction, or that I would say right now we don't have the answers yet. Yeah, but more opportunities. And as I said, the digital revolution is going on, but still little attention is being paid to this aspect. And I really don't know how to push it through. And unless, of course, the healthcare system is become totally sensitive to these things as far as digital health interventions are concerned.
Can I add? I think that is the role for nursing in digital health. I think it is our proximity to people and sort of understanding the need for that relational approach. And I think working with folks developing interventions and computer scientists, I think sometimes they're a bit surprised. And I know Leanne Curry talked about this when we started doing some of our digital health work. She's like, they're not going to know how many patients you can access and how you should talk to people and how they won't know about and feel comfortable with your proximity with your population. And I think that's our strength, is kind of keeping that as the central focus. And how do we push it through? I think it's conversations like this where we have a great idea, and then conversations continue, and that's where these sorts of maybe ideas get fostered and turn into something more. But I think nursing, that is our strength in the digital health world, is that proximity to people and knowing that the relational piece is important. So how do we do this digital health work but maintain that closeness?
Great. Thank you so much. We're getting ready for time. We probably have time for one more question, if anybody has anything. No? Okay. Oh, sorry.
The
broke my wine glass. You know, we've seen technologies used for generating profits and generating greater profits. So de-skilling is something that always comes to my mind, that people can use sophisticated technologies to simplify work, to reduce the scope of work. Do you see that as something that's likely to happen? Do you see that as something that is happening and that people will need to push back against in order to maintain a kind of, you know, holistic care?
Who would like to take that one? Everybody's so kind here. And
I mean, yes. And I hold multiple, I don't know, considerations with this, but I've seen particularly, and I'm down in the US, but, you know, particularly with the pandemic and with sort of what has happened with the nursing workforce, which was already sort of struggling, but not just struggling intrinsically. It was struggling because the business model has become one where we run, like lean startup, we run on, you know, the bare minimum. And if anything fails, then everyone else has more stress. And that stress perpetuates more stress. And that stress creates an argument then to introduce technologies, which on one side, we know this is the thing with nursing, we need people who are having care needs now, those care needs to be met. So I'm going to take whatever I can to meet the need. At the same time, though, in that introduction, it becomes fairly easy, I think, to then argue, oh, well, we have this tech, and therefore we don't need to invest in safer staffing, in more robust models of care, in building the futures that we don't just want, we need if we want actual accompaniment. And that's the slippery slope. I don't even think it's a slippery slope. I think we've sort of fallen down it in some spaces, and where we do run the danger that as the sort of techno-solutionist side gets more investment, the labor side and the human relational side may have less attention, but be told or even gaslit that, well, look what we're doing for you. And that's where collective action and relationality among workers, as well as patient advocacy groups and others, is really important, because tech isn't intrinsically good or bad. It's not that this whatever thing I have here to help me, I don't know, assess a wound is bad. It's just that there's a bigger picture. I think, you know, all of the panelists I've now spoken to that we need to keep in mind. And unfortunately, at the decision point, that's often with whoever has the budgetary authority. And that's not necessarily the lens that's being applied unless we force it to be applied. Is initial thoughts.
thank you so much. It's 6, so I'm going to wrap us up here, but I just really want to say thank you so much to our panelists who are willing to come out and share your expertise. I think it's been just a great conversation, and I think it's going to carry us really well into our dinner break in the atrium, where we can continue our conversations, and in the atrium for our in-person audience. We are pleased to have food from the local catering company, Tabay, which specializes in Syrian cuisine. And this unique social enterprise and food venture empowers newcomer Syrian women chefs. And we have worked with them before, and the food is delicious, so I invite you to partake. And we've kept it very simple. It's a box style, so people can move around and talk. And we'll invite you to come back in for 7 p.m. for our keynote lecture with Dr. Ray Walker, who is here with us today and has given a great insight into where we're going to go. And for those of you who are online, I'm sorry if I didn't get to all of your questions, and you can stay online, or you can relink back in. Yeah.
And we have had technical difficulties this whole time, and apologies.
Okay, so yes, for those in case you haven't heard, we have been experiencing some technical difficulties, and we have a team that's working to sort it out, and we apologize for that. And again, you can stay online or re-link in back with us for the same link that you used for this. So thank you, everybody. Have a wonderful dinner, and we will see you all back at 7. Thanks so much.